Hello and welcome to this education session on tracheostomy management. This is just a supplementary education material for if you ever have to deal with a tracheostomy patient and help them with their troubleshooting. I would like to give a thanks to West Zone Education Department for assisting with the majority of the information in these slides. So just starting off, when we deal with tracheostomies, it's kind of nice to know where things are in the throat here. So usually tracheostomy is placed below the level of the cricoid membrane to allow speech and eating and swallowing for our patients. So they can have some kind of normal lifestyle, normal functioning, especially if it's going to be long term. Another reason patients have these placed is that usually consensus in hospitals is that if the patient is going to be intubated longer than 10 days, they would consider doing this as opposed to regular endotracheal intubation. And this way they can keep it on there and possibly use it at home after therapy for longer term support. So as you can see here, it lays down in the actual trachea below the cricoid cartilage. Other things considering with anatomy, there's a difference in terminology and what's actual procedures are being done to these patients. So the first one we look at here is a laryngectomy. So the picture on the right there. So laryngectomy is a procedure which alters the anatomy of the upper airway and actually results in breathing that occurs only through the stoma. So with these patients here, so a lot of times cancer patients, things like that may have their entire larynx removed during a total laryngectomy. So with these patients, it's very important to remember with laryngectomy that they actually don't have an upper airway access to their lungs anymore. They're breathing entirely through their stoma and their lower airway. Versus on the tracheostomy there is that the upper airway is still intact. So with these patients, if they do have a problem with their trach, they may still be able to breathe through their nose and their mouth just like a normal patient. So that gives us options for ventilation. So when these patients do have their voice box removed, they do get a permanent stoma put into place. And this is different than a tracheostomy. So when we talk about a laryngectomy stoma, this is how the patient breathes. And this is important to know because the connection between the mouth, the nose, and the lower airway is closed. It doesn't work. So this might be a permanent placement for laryngectomy patients. So this is why it's important if we're trying to ventilate our patients, assist with ventilations, we need to know what's happening with their anatomy. Some other things to know are just the actual definitions when it comes to what we're dealing with certain types of tubes. So if you have a fenestrated tube, as you can see highlighted in the picture here, it means there's openings in the tracheostomy tube that allow airflow through the device. But with fenestrated tubes as well, if the inner cannula is removed and the cuff is deflated and the normal passage inlet of the tube is occluded, a patient can actually inhale and exhale through and around the tube. This works for them because it allows them to talk. So what happens is because the air can move in and out, go past the vocal cords at the back of the throat, they are actually, or behind the tube, sorry, this will be able to result in them being able to speak and communicate normally. We have cuffed and uncuffed tubes. Obviously, the cuffed tubes have cuffs. So with the cuffed tubes, they have a pressurized balloon that just straight up occludes the trachea to prevent airflow around the device. And this might be used to help protect the patient from secretions or foreign material entering the airway itself. This is used usually when people are on long-term ventilators, like in the hospital, things like that. With an uncuffed tube, they may be more long-term at the home. But again, just the difference is you do not have a cuff on that one. When it comes to speech, it's very difficult to speak when patients have tracheostomies. So like I said before, they need to pass air through the vocal cords, which may not happen if they have a tube in place. But with that, they may have speech valves or they may have special cannulas that allow them to speech. So with these ones have a one-way valve designed to allow air into the tracheostomy device, but not out. So that way it forces the air out through the trachea. So that way it goes up the larynx through the vocal cords and actually allows the patient to talk. Some actual tracheostomy devices themselves, a lot more common. You're seeing them more and more in the field now. And usually, again, long-term, they're used in the hospital. Better for weaning patients off the ventilators in the ICU versus long-term endotracheal intubation. And it can just allow for greater functionality out of the hospital. And the patient can usually handle them by themselves at home. So one of the first devices we're going to look at here is your tracheostomy devices. So the first one here is a stainless steel. So these are original ones, like it's kind of old school. They're not commonly used anymore, but patients with the devices previously sometimes opt to continue to use these instead of using a newer device. And sometimes these devices are also used with patients who have difficulty with chronic infections, or they just have allergies to the plastic or silicone devices. So they're just that contact irritation of the throat, but not really something we're going to commonly deal with. So other tracheostomy devices here. So we have a cuffless trach tube. So with this one, it's a very common device. Patients often self-manage these outside of the hospital. There's a lot less risk of pressure injury or esophageal tracheal fistula just from the pressure of the cuff constantly eroding the tissue because of constant pressure. So it's more common patients moving towards decannulation without the need of a speaking valve. Cuff trach tube, like I said before, is usually used more so for patients requiring constant positive pressure ventilation or ventilatory assistance, or can't protect their own airway. So either any of these devices, they all come with a disposable or reusable. You can actually clean them and reuse them. A reusable inner cannula. Some devices do not accommodate any cannula, usually just due to size constraints. So when we think of like pediatric stomas, they have very small lumens. So if we put another tube inside there, it's not going to be adequate enough size to get enough air movement in and out of the patient. So again, like shows here, so you can see these are very small, these pediatric trach devices. So these ones will just have the single catheter going in. They won't have the inner cannula. So with this here, so we talked about the fenestrated tracheostomy tubes, the speech cannulas to assist patients in breathing on their own or possibly in helping with their speech. But the other one there is the subglottic suction cannula. So this is located on the exterior surface of the cannula as a completely separate lumen. So this can be connected to intermittent or continuous suction as intended for evacuation of secretions above the tracheostomy tube cuff. So if there's something actually stuck in the tracheostomy device, then we can suction that. But if it's anything above where, like, say, the cuff is inflated, we can then suction that area. So when it comes to dealing with these patients, it can be intimidating. They have a hole in their throat and there's a tube in it. So we're kind of like, oh, what do we do with these patients? This is complicated. But realistically, it's common practice. And when patients go home with these, they are trained on how to clean them, how to deal with them themselves. And replacing an inner cannula might be a daily occurrence for these patients. So we're basically just going to be there to assist in their care. So one thing we have to worry about is secretions. Again, this could be something where they just get a lot of secretions. They can get colds, pneumonias, things like that, especially like if they're on a ventilator, they're at risk for pneumonia. They may get something stuck in their cannula, such as this. So with this here, patients with trach tubes can have some buildup that needs to be cleared, but some cases it may be very difficult to do that. So we need to take it out. And in the worst case, you might get a mucus plug forming along the lumen of the trach tube and completely obstructing it. So the easiest troubleshooting step is to remove and replace the inner cannula present. So patients often have a supply at the home that they're supposed to change it on the daily. The worst case scenario is that if they're out of these tubes, we remove the inner cannula and we just don't replace it. They still will be able to breathe with the tube in place. And like I said before, some of these can be washed. So if the patient is aware and has the proper solutions to clean them, we can assist them with that. So we can take it out, clean it out, and then reinsert it for them. Okay. When you remove these tubes out of their trach, if they have a speech valve, you just unscrew that from the end of the cannula of the interior cannula first, and then take the tube out. To take the interior cannula out of the patient's trach, you just carefully twist it. It should unclick and then just slide right out. It's not a huge procedure. Again, patients should be able to assist you with this. The big thing you have to be careful of is to not pull the outside trach device out. So we want to hold the neck plate with one hand, like you see in the picture here. With the other hand, unlock the inner tube. Again, just gently rotate it and then remove the inner cannula. If you have trouble removing that inner cannula, don't force it. Just look at other options. Suction might be your next option for these patients. And please, please, please be very careful not to remove the outer cannula. That's what's inserted into their throat. So with our patients, if suctioning is required, so we don't want to take out the actual interior cannula, but we need to suction because they've got whatever it is blocking their tube. We want to try and pre-oxygenate patients as much as possible while we're getting ready to do suction. Because again, if they're having trouble breathing, just like any other patient, we want to give them supplemental O2 to help bring up their SATs and just deal with their hypoxia. So while we're pre-oxygenating them, we're going to decide what size suction catheter we're going to use. So if we first look to the side there, so we try to decide the size of the suction device by looking at the interior diameter. So as you can see, the arrow here is pointing to what size it is. And then we're going to multiply that by 2. Okay. So as we see there, the interior diameter is 6.4. We multiply that by 2 gives you 12.8, rounded off to 13. So whatever number we get, we go down a size in the suction catheter. So for this patient here, because we figured out the number is 13, we're going to go with a size 12 or 10 French suction catheter. We look at the next example here. So we have an interior diameter of 3.5. Multiply that by 2, that equals 7. So therefore, we use a size 6 or 4 French suction catheter. Okay, so that's how we determine the size. Next question is, how far down do we go, right? We don't want to be suctioning right to the bottom of their lungs. So to measure the insertion depth for these devices, we use the end of the airway device. So at the end of the tracheostomy tube, at the top of the mount, and then we measure down to the sternal notch. So because that's where the carina sits, as you can see in the picture here. So with that, we measure the right length. So we go from the opening of the tracheostomy down to the sternal notch, and then that's the length we go in. So we shouldn't go any further than that. So you can mark it off a tape or just hold your fingers there to determine how long you want to go into the patient's throat. So with that, like we do normally when we suction the oropharynx, we don't activate suction as we put it in. We insert the tube to the proper depth, and then we activate suction as we withdraw a twisting motion, such as this. So we want to make sure we're twisting that tube as we withdraw, and we don't do it for more than 15 seconds. Again, just like when we suction the oropharynx, we're always worried about causing more hypoxia. The patient may not be able to breathe. It's actually recommended to try and do suction while the patient is exhaling. If there's very stubborn or very thick secretions that might be hard, like they're just stuck there, maybe that's why the patient needs that help. You can actually put in about 3 to 5 mLs of saline into the trach and then just suction right away. So get your suction tube in there, put some saline in there, and then suction right away, because obviously we're not going to start pouring saline just down their throat and just let it sit. So we want to get that 3 to 5 mLs of saline in and start suctioning right away, and hopefully that'll loosen up whatever the phlegm or clogs in the trach are. When it comes to ventilating this patient, so these patients should have a standard universal adapter, similar to what we would on our iGels, ET tubes, things like that. So if we need to ventilate these patients, we should ideally, in a perfect world, be able to just hook them up and ventilate through their tube. However, in some circumstances, we will need to ventilate from above. So if we have a patient that has that full laryngectomy or laryngectomy, sorry, yep. They may not have an upper airway that we can access. So when you're going to resuscitate these patients, you actually have to do like BVM to stoma and actually ventilate through their stoma because their upper airway isn't connected with their lungs anymore. The other thing you might have to look at as well is that if there is an issue and we need to ventilate up from the upper airway, we may have to occlude the airway. So if they have a tracheostomy, we may have to cover that site to assist ventilation. So that way we're going to ventilate through the mouth and nose because they still have that open airway higher up. We're going to ventilate through there. And that would be the same if we're still using an iGel. So we want to cover up that stoma to help prevent air coming out of it. We just want to go right through the mouth and the nose. Other things to consider here, just a couple things. So this might be one that you come across when you're doing an IFT, is that if you are providing supplemental O2 by a trach mask, it should be humidified. So because the air going into this patient completely bypasses nasal warming and just oral warming and just that humidifying that your body does as it goes down, it's going to be very dry. It's going to be very irritating to the respiratory mucosa. So ideally, if you're going to be transporting these patients, they should have humidified oxygen. Another adjunct here as well is if you're giving supplemental O2 versus a trach mask, or if you just have access to the trach, what we can do is that there's actually some ports. We don't carry these on our trucks. Again, this might be something the patient has in the home or during their IFT. And as you can see in the picture there, it plugs right into the patient's stoma. And then we can just take the MDI container out of the puffer, hook it up to the tube, and we just give the medication through there if required. So if they're having an asthma attack or some kind of bronchospasm. And that's our quick review on how to deal with tracheostomies. Thank you very much.